Hello, and welcome to today's Patient Engagement HIT webcast sponsored by Oneview, how a digital patient experience platform improved our patient, family, and clinician experience. I am Vanessa Palmer-Desiato, Project Manager at Excelligent Healthcare Media, a moderator of today's webcast. First, I'd like to thank our sponsor, Oneview. Oneview Healthcare provides digital tools for patients, families, and caregivers to improve the care experience, unifying a facility's systems, content, and services into one digital platform with dedicated devices at the point of care. Oneview helps deliver more control for patients and families, more time for care team, and less cost and complexity for healthcare organizations. Audience members can submit questions at any time during the webcast using the question tool to the left of the screen. A recording of this webcast will be made available following this presentation. For all technical matters or difficulties, click the help icon at the bottom of the screen. Today's webcast will begin with a brief introduction of our speakers. Then we will talk more about NYU Langone, reimagining the inpatient digital experience, pre-pandemic life, COVID-19, and the shift to post-pandemic, and then conclude with a question and answer segment. With that, I would like to introduce our speakers for today's presentation from NYU Langone Health, Dr. Paul Testa, Chief Medical Information Officer, and Ruchi Patel, Senior Product Manager. Dr. Testa, I'll now hand the floor to you.
Thanks so much, and a pleasure for everybody who is joining to have us tell you a little bit about our story. NYU Langone is a large academic health system based in New York City. We are spread out amongst 5 or 6 different hospitals and many ambulatory locations. We're kind of proud of the work we do, and we're proud of the innovation partners we join with. I'd highlight that any kind of engagement platform, such as the one we're going to talk about today, really is a frontline tool. And I would really highlight the importance of how much nursing has been a partner with us in this. And to that end, we've really we shine in our magnet designation for our nurses for 3 times in a row. We just got that. Happy to point out. This I offer only to highlight that when we were looking for a partner and something to deploy, it needed to be viable in a slew of different care venues, from a frankly small community hospital to a large tertiary care and procedural-based brand new hospital that Ruchi is going to talk about shortly. So we're 2,100 beds inpatient at any given moment. We're about 7+ million encounters and patients in our EHR, as well as 4, if you add a standalone, we're 5 EDs at the point. We have 4,100 physicians on staff, and we have a large number of residents and fellows, as well as our number 1 user, nurses, of our clinical systems. Over the last 15 years, technology transfer and innovative use of digital health has been paramount to us. And it's been a true goal of ours to grow this, and we've done it successfully. As a CMIO, this is sort of my merit badge, most proud slide. It's important to us that we implement clinical systems and digital health solutions that augment and don't get in the way of the provision of care, but rather provide higher quality care and better care because of what we implement. We set out now about 3 years ago to look at our digital experiences and how do we innovate around those and foster the touch points between the different users we have across our system, because frankly, we serve everybody as digital health mavens sort of in our own system. What was required and what we found to be most successful was the need to link leadership, clinicians, operations, and us IT, as well as communications, to bring together those technologies with patients and their families. So we were able to innovate directly with some select partners, Oneview being one of them, 5 or 6 other large partners such as Oneview, and then many other startups that we work with. It really was a culture of collaboration, and integration is what we sort of refer to as our secret sauce. We can't have clinicians bedside, or patients for that matter, moving between multiple apps and multiple platforms. So when we talk about digital experience, it evolved. 3 years ago, we sort of set out on this patient digital experience, PDX. We very quickly realized that it's hard to to impact the experience of a patient and not equally address the clinician digital experience. So we have stood up a deep, programmatically driven clinician digital experience, as well as PDX, which we'll talk about today. But that spawned research digital experience, our educational digital experience, and then our workforce digital experience, which impacts all of our 42,000 employees. It was a significant and strategic investment in our digital assets that allowed us to get to where we are today. And I'm going to hand it to Ruchi to speak about how we reimagined our inpatient experience with our new Kimmel Pavilion.
Thanks, Dr. Testa. So in speaking about those different digital experiences programs that we have, at the heart of our patient digital experience is really user-centric design. And with the Kimmel Pavilion launch in 2018, we really had an opportunity to innovate and rethink our digital experience and our technology footprint to create and design a new experience based on the needs of all of our users, not just the patients, but also their families and the care teams that really partner together in the care journey. So we really wanted to design our systems in a way that was holistic and didn't negatively impact any of the other systems that we had in place, as well as all the operational workflows that were needed to support all of this care journey. So we really thought about it from a 360-degree point of view, and going into the design process for what technology we wanted to put in place in Kimmel, we had a number of different design business goals and user goals. So some of those are listed here. For example, business goals to replace the physical whiteboard, reduce the use of paper handouts, have a system from a patient digital experience that's easily expandable to add new features over time, integrate with our existing clinical and non-clinical systems, so our electronic health record being, of course, the #1 thing, but all of the other systems that can support as well, such as our room control system. Ultimately, the goal was to improve the patient, family, and clinician experience while leveraging our NYU Langone branding. And then from a user perspective, really facilitating and prompting some of those open communications about care plans, provide entertainment and ways for patients to distract themselves, as well as personalizing that patient experience in a way that is unique to each patient and to their visit. So our approach to designing this way back when we were designing it for Kimmel was really in this 5-step process. So initially we did some discovery work where we spoke to a lot of these different user groups that are within those different categories. So patients, families, and the care teams as well, through advisory councils and various focus groups. If you've done this exercise before, you'd recognize that oftentimes this leads to a significant amount of volume of patient feedback and information, which then needs to be synthesized and parsed into something that can actually become actionable. So our second step was really to synthesize those needs into problem statements that we could then use to create a vision and a solution and come up with a minimal viable product for what we actually wanted to start with. Once we had that initial product idea, we then set out to rapidly build and test using prototypes, again with those focus groups and advisory councils, to see what really worked and what didn't, and try to iterate quickly before really putting down any single line of code or purchasing any single product. And during this entire time, in parallel, we were really out looking into the market to see what products were available that might be able to meet some of the needs and those goals that we had in mind. So we set out on this journey to find that, again, holistic, integrated product that can work with our workflows and meet those business and user goals that we had in mind. We spent a number of months going through an RFP process where we looked at a number of different vendors and eventually settled with the Oneview healthcare product. So the product coming from Oneview really did meet a lot of those goals that we had from a feature perspective in terms of the capabilities of the product, as well as being able to support the idea that we wanted to continually expand and add on over time without a significant amount of overhead. We also had an opportunity with Oneview to really build their roadmap together and partner with them to innovate and to ultimately be able to scale this product across our hospital system. Here you can see a handful of some of those product goals that we initially had in mind. So this is certainly not an exhaustive list, but it does cover a few of them. So advanced healing, increasing patient satisfaction, and increasing revenue are kind of three of those buckets of goals that we had for this product. Under each of those are just a few of the things that we were really looking at. So to what we described earlier, things like empowering patients in various ways. So having education that explains to them what they need to do and what they need to know to be part of their own healing journey. Empowering the patient support network to also be connected with the patient and help once they leave the hospital, as well as while they're in the hospital from a support perspective. Patient adherence with the care plan, and then increased transparency, for example. Under patient satisfaction, things like distracting, relaxing, and entertaining the patient while they're in the hospital. A hospital is obviously not a place where anyone ever actually wants to be. So being able to have ways to distract your mind from whatever pain or discomfort you might be in, as well as different aspects of feeling like you're still connected to the outside world and having a sense of control over your environment while you're in the hospital setting. So the product that we ultimately landed on, again, was with the Oneview platform. And this is an example with this picture of what it looks like in our Kimmel Pavilion. So in the Kimmel Pavilion, the product that we put in place has two different components to it from a physical interaction design perspective. We've got a tablet that's on an overbed table and a large 75-inch screen on the footwall that's controlled by a pillow speaker and connected to a computer. So multiple components really come together, and combining that with our deep integration into our electronic health record system and a number of other systems, we are able to provide a patient hub that ultimately empowers patients, families, and those care teams that they're working with to really partner in their care journey. So let's walk through what a few of these different screens look like and what patients actually have access to. So here you can see what the home screen looks like of MyWall. And what we've done with this is really thought through some of those different aspects of the room that may have existed in the past, like those whiteboards, and actually added them here. So things like the patient's name, the date, the care team who's taking care of that patient, the room that they're in, the discharge date, among others. These are all things that previously would have been listed on a physical whiteboard in the room. And adding them here allowed us to remove some of those elements in the room and then use that space for other things. Other aspects that you can see here of the system that include really that deep integration with Epic and other systems include the fact that the care team really does come from Epic and is updated when a nurse, a provider, or another member of the care team actually updates their assignment within Epic. It flows straight through. So the patient is always seen as most up to date at that point in time, even if, say, for example, a nurse shift happens. The patient's preferred language is also something that comes through from Epic. So for patients whose primary language is not English, the system does actually completely translate the entire user interface to that patient's preferred language so that they can navigate and use it in the language of their comfort and what they're familiar with. The discharge date, again, also comes from Epic. And then meal ordering, which I'll go into a little more detail on the next slide, includes some functionality from Epic as well as what the patient themselves imposes as far as dietary restrictions. Other things that are included here include patient education, which can come from Epic as well. And through our design process, we actually learned some interesting things about the power of words, where through those feedback sessions early on, in one of our initial prototypes, we used the phrase assigned patient education. And a lot of feedback that we got was that people associated that with homework, and they were taken back to their child life as a child when they had to get assigned homework and complete it. And people did not take very well to that. So we actually renamed that to Education About My Care. But that's just one example of how feedback sessions really allowed us to ultimately create this very simple user interface that a patient can navigate, whether they're a younger person used to using tablets or an older person that maybe hasn't got that level of familiarity with technology today. They're still able to use it. We've had 65-year-olds equally navigate just as well as a 10-year-old, for example. So here we've got the meal ordering screen, and this is actually one of the most popular pieces of functionality that we have in the system. Whenever I ask anybody what their favorite feature of MyWall is, it's actually this. And the reason is very simple. It allows those patients to really feel like they have a sense of control over what they're going to be eating, and it also includes any dietary restrictions that are imposed by either themselves, such as being vegetarian, or by a provider. So for example, if they had to be on a liquid diet or a low sodium diet or whatever the case may be for that particular patient and their visit, that all comes into play here. And the menu that the patient sees ultimately is only a menu of items that they can actually choose. All of this to say, it's not just a standard food tray that most places provide. Under the watch and relax section of the system are most of our entertainment options, where we have a combination of entertainment that we provide. So NYU Langone providing generic content like TV channels, movies, and relaxation videos, as well as anything that can be personalized. So consumer grade applications that patients can log into using their own personal logins, allowing patients to have that personal feeling where they can pick up wherever they left off on, say, a Netflix show that they're watching, or log into Spotify and use it to listen to music that they're interested in, and not just generic content that we have available. Sometimes we found that patients really use these features and functionality in the way that we would expect them to. And sometimes we find that they actually use it in different ways. So one example of something that we expected and designed for was those two pieces of hardware in the room. So having the tablet and the TV be able to operate independently but still paired allows for pediatric patient families to really make use of both devices at the same time. So we've seen pediatric patients plug in their headphones, be sitting there watching Netflix while their parents are in the room and actually watching patient education together, using the larger TV that's in the room on the foot wall. And then other times we've actually found care teams being creative with the content that we have as well. So for example, again, in the NICU, I've actually personally seen it myself where sometimes the nurses have put the tablet physically close to an infant and using the tablet speakers and the relaxation content, using that to really help some of these infants fall asleep and stay asleep with the soothing sounds that are available to them. We also have a few different ways for pediatric patients in particular in our Hassenfeld Children's Hospital to engage with the live events that are happening in the building. So for example, let's say Mariah Carey comes by and is doing some sort of live event, celebrity event, within our Hassenfeld Children's Hospital. There's a broadcast studio there that can actually broadcast the feed to MyWall. So that would allow any patients who are physically unable to attend the event in person to still engage and be a part of that event, including things like trivia and any other event that's happening there. Then in terms of connecting with others, we've also got a whole host of different functionality that we've added to the system and integrated with it to really allow patients to connect with various different groups. So that can be providers, it can be their family, friends, whoever it is that they need to connect with or want to connect with. And in the Kimmel Pavilion, we actually opted to use a soft phone, which allowed us to forego having a physical phone in the room. And with that custom soft phone, we're actually able to have the phone number follow the patient so that if they're transferred from one room to another room, the family has a single phone number that they can use to contact that patient no matter where they are in the building. Some of the other functionality that is included here we'll get into a little bit as it pertains to COVID, but things like telemedicine, interpreter services, and the proliferation of Zoom, which really was something that took over during the pandemic in terms of a way for patients to be able to connect with others. So pre-pandemic, life was a little bit different than post-pandemic, which I'm sure all of us can certainly attest to. So pre-pandemic, MyWell really came in these 4 different variations where we had something called patient mode and something called guest mode, and then combinations of either tablet by itself, TV by itself, or tablet and TV together. So those 4 variations really allowed us to flex the product and be able to adapt to any different variation of clinical need and clinical setting that we could possibly need to put this product into. So we kept in mind a couple of different design constraints when really thinking about what to deploy in a particular unit or a particular location. One was facility constraints, like literally the infrastructure that's in the building. Sometimes cabling limitations, network limitations in older buildings might impact what you can provide. And other times, things like the clinical specialty or the unique patient needs that exist for that particular specialty, that can also influence what it is that we actually want to include in terms of features and functionality. So for example, a dialysis or infusion patient is someone that's often a returning patient. They come in repeatedly for a similar procedure or treatment where they're fully lucid and not typically moving around. They're there for maybe a few hours during one day as opposed to multiple days, and then they leave and come back again later. The needs for that type of patient in that type of environment are going to be fairly different from someone in an inpatient setting where they might be staying overnight. They may be there for weeks or days or weeks on end, maybe even months. And things that are attributed to really creating that feeling of comfort and control, like the meal ordering, being able to control the lights, the room temperature, the shades in the room, those kind of things really come into account a little bit more. So being able to, for example, provide the room controls and the ability for a patient to themselves be empowered to close the lights or close the blinds or reduce or increase the temperature of the room on their own from their bedside really allows us to return time to the hands of our care teams to be able to spend time on patient care as opposed to doing some of these request type things that a patient may have previously been asking a nurse to help with. So in terms of a timeline of what we've done from Kimmel until now, again, in June 2018, we really seized that opportunity of reimagining what that inpatient digital experience might look like and launching the MyWell product within 500 beds in our Kimmel building. Since then, in 2019 and 2020, we branched out a little bit using those 4 different variations of the product and really putting it into different clinical settings than we had in the Kimmel building. What you see on the top there are 3 different examples, one in a dental suite, one in an orthopedic hospital, and one in an infusion location. Then in March of 2020, the pandemic hit, and that really changed the dynamic for everybody in every walk of life. And we'll go into that a little bit a couple slides further down. And since the pandemic has somewhat scaled down, we've been now looking at really trying to scale rapidly and bring this really great patient experience to all of our different locations across our hospital system. So now COVID-19. So COVID obviously changed everybody's life in a number of different ways. And when COVID first hit, New York City was at the epicenter of one of the first outbreaks in the US. We didn't know what was going to come with the virus. We didn't know how any of our tools were going to get used. We didn't know what was going to happen day to day or change from one moment to the next. Ambiguity was high, and the need for something that could adapt quickly and be deployed quickly was really at the forefront. We really had 2 main reasons for connecting different groups of people that became apparent very quickly. One was to connect providers with patients so that we could get them connected virtually without having to have anybody walk into the room. And second was to connect patients with families so that, in a time when we couldn't have visitors coming in as frequently or at all in some cases, patients didn't feel isolated and alone. during this time that they were in the hospital, especially if they were there for an extended period of time or if their family members were also in the hospital at the same time. And there was really an added layer of urgency to really get it right the first time. So with COVID, if a solution was deployed in a particular room, we didn't want to have a tech physically put it into the room, set it up, walk out, and then have to go in 3 days later because we needed to update something. So at the time, Oneview had actually reached out to us with a proposal for a cloud-based version of their product. Up until now, everything that we'd used was their on-prem version, which required different resources and different infrastructure to be in place for us to be able to deploy something. And typically, it would take a number of weeks to really be able to take something from start to finish, weeks or even months at times, depending on the level of integration, to get something deployed. The Oneview solution that was being proposed sounded like something that we'd be able to use much more quickly, much more easily, leveraging the cloud and really Oneview's resources to be able to deploy quickly and update easily as needed. So this is what the product essentially looked like from a patient perspective. So in terms of the physical product, very similar to what we had before with the tablet, and the user interface relatively consistent. The patient would be able to use it to do whatever they wanted to do in terms of using entertainment to distract themselves, connect with whoever they wanted to, the same sorts of things that were in existence on the on-prem solution. But then they could also connect with their provider and return to that home screen to do what they wanted to do. But this solution was something, again, that we could deploy much more quickly and rapidly, but still with that core ability of being able to adapt it as needed without having someone walk back into the room because everything was controlled by software. Now I'll hand it over to Dr. Testa to talk a little bit more about our COVID experience.
Thank you, Ruchi. So many of you will be familiar with the stacking diagram. On April 4th of 2020, this was our main, our largest hospital in Manhattan. And that magenta color, for lack of a better word, was the destruction brought across our inpatient facilities and represented COVID dedicated units. So be it clear, essentially every bed in every one of our 5 hospitals became a COVID bed and COVID units. We were completely at capacity, actually exceeded capacity, with COVID patients. The power here is this happened incredibly quickly, and as Ruchi said, we had incredibly powerful and well partnered clinical and operational leads. We had to get this right the first time. I woke up on March 30th to this tweet from one of our senior researchers at NYU Langone. And it's a picture of our brand new pavilion wall on the left. The walls where nursing and the teams started leaving information in dry erasers on the glass doors. And this was applauded as an innovative solution. I am a clinician. I get it. You solve the problem and you move on as fast as you can and as safely as you can. But when I saw that morning, I was like, we can do better. And this is signal amongst the noise to say what we needed to do. The photo on the right was from my chief operating officer, who texted it to me the same day as the tweet, of how innovative he thought this was, which included also PHI written on the wall, with the progression of the O2 needs of a particularly sick COVID patient. So if you look in that antechamber between the 2 glass doors, that is Epic Monitor, which essentially has it's a really high-end ELO touch screen that has essentially every piece of information that is on that piece of glass digitally updated regularly, but now rendered completely useless. But do you know what wasn't rendered useless? Go through the next door, and you'll see on the foot wall the Oneview, the My Wall screen, and paired with a tablet that's out of view from there. So I can't get through the Epic monitor, which we eventually rebuilt and deployed on provider and nurses' personal and issued devices. And we created reports that had all this information for them to access in real time. But we fortunately had a foothold, no pun intended, at the footwall with our MyWall solution. So these tweets came out and the email came out, text to me came out, it almost perfectly timed the worst of it when we were in the midst of really the worst of what we saw. And this was also shortly after Oneview came to us and offered us this cloud solution that became something we could deploy where we didn't have a brand new pavilion, but in our other facilities. So the care model changed. We couldn't get into rooms easily. We were in desperate need of conserving our PPE. We needed to protect our patients and our caregivers. The state suspended visitation. So we had patients dying in our rooms and in our EDs essentially alone until we could get video connections to them. And that was probably what hurt me the most living through this experience was there was no reason that patients needed to, or nurses needed to activate their own FaceTime to try to have a patient say goodbye to their family member in these last 30 minutes of their life, which was happening all the time. So in conjunction with Oneview, we had immediately expanded 500 additional cloud-based tablets that we could deploy our telemedicine integrated with Oneview solution in these rooms, in large part thanks to Ruchi and her team's work. We needed something turnkey, fast, that was a hardware software solution, worked on our Wi-Fi, was managed, simple, and provided that force magnification. We looked at the dedicated, telemedicine carts, which were, between $15,000 and $35,000 a pop. They required heavy touch, and when the software updated for those, or for our own sort of makeshift devices, it also required us to actually touch the devices, even when they're device managed by our own MDM. So an army of tablets was deployed, and our clinicians were able to monitor patients. Our nurses all have, we've deployed Rover, but we also have Jabber, Cisco Jabber on our nurses' iPhones that we give. It's a role-based phone that they rotate through. But we were able to install these on anyone's smartphone as needed. It also, one of the very first, I got a phone call from a nurse manager who told me that she had a husband and wife in not next to each other, but a few rooms apart. And they essentially created a telemedicine bridge between those two rooms. We did lose one of those patients, unfortunately, but they were able to connect, which was an amazing thing in an absolutely horrible time. So this is what it looked like. And we quickly saw that we were conducting about 1,000 questions a day, 1,000 video visits a day. And that has maintained. Even post-COVID, it's finally been proven that we can do this in the inpatient setting. And I would say a lot of this integration came out of the box deeply within Epic. I'll have Ruchi speak to that in a second. But we were deployed with an army of nurses, and that's our chief hospitalist on the right and one of our nurse informaticists who was quickly deploying around the units to get these live and inpatient rooms. So I'm going to hand it back to Ruchi to sort of talk about where this leaves us now.
So post-pandemic, we're now, again, looking at everything and trying to create these consistent patient experiences for all of our inpatient hospitals, as well as some of our ambulatory care practices as well. And in looking across the board at everything, there are common themes that we can find based on the clinical specialty and the expectation of what a patient is going to be doing and what their needs might be for that particular type of unit. So going back again to those principles of our patient digital experience and trying to think holistically across the board, we're looking at all of this to try to create those standard packages that we can then deploy to each of these different types of unit. So no matter which NYU Langone hospital you come to, you're going to have that similar, really modern experience with all of the great functionality that comes with the Oneview platform. In addition, on the entertainment side, some of you may have a similar problem to what we're going through now, where as we've acquired different hospitals and acquired different buildings or open new buildings, older technology in the building from an entertainment standpoint, so purely just TV and the delivery of that, can be different because different buildings, different hospitals, they have different things going on. So taking that holistic view, again, of all of those different things, looking at what we've got and seeing how we can ultimately get it to the point of having this consistent patient experience, no matter where a patient is coming in. And then finally, what we've been talking about here throughout this entire half an hour or so is really just all of the different ways that NYU is working towards making this something that we can scale and operate easily. So building that initial foundation with the Kimmel Pavilion, from the infrastructure in the building, the network, the cabling, all of the things that need to exist for the technology to even work, to the integrations with Epic, with our meal ordering system, with our room control system, among others. Having all of that initially done within Kimmel gave us the experience that allows us to then continually use that going forward as we try to scale this product elsewhere. Combining that with Oneview's scalable software, we can create these standard software packages, and then with their cloud product now, including and leveraging testing automation, continuous integration, continuous delivery pipelines, we can then deliver value to our end users, whether it's the patients, families, or the care teams, much more quickly than we have historically. And then those two in conjunction with having standard form factors that we can use for different clinical settings. So again, in a dialysis space, for example, if a patient is reclined, they may have a different need than somebody who is in a bed or a chair. So even just thinking through some of those interaction design aspects really creates this ultimate total product package that we can then put together and create this consistent digital experience everywhere. And then finally here, just a few of the lessons that we've learned over really the last 3 years, not even just from COVID, but across everything we've done with the MyWell platform, on-prem and cloud. One is that user feedback loops really are key to investing in the right features, and really in making the features that you are deploying done the way that people really respond positively to. Trying to balance standardization with customization. While we might want to provide a really customized experience everywhere for everyone, that may not actually make sense. And from the standpoint of supporting the product, standardization really helps. Having flexibility allows for that rapid iteration and the ability to adapt to changing needs very quickly. And that, with COVID, could not be more clear that that is something that is very important. Cloud and automation can reduce those deployment times and again, try to get value to end users as quickly as possible. And finally, scaling really does require having that right foundation in place for the house to really be built upon. Without that, it's going to be that much harder to be able to put this out there once, let alone over and over and over again to newer and newer places. And then Dr. Testa, if you want to wrap up.
Thank you, Ruchi. We're going to hand it back to the team and to the participants. Thanks for joining for questions. I think there is no way to not look at this as part of the holistic digital health strategy of the enterprise. And that's really what I wanted to, Ruchi and I both want to highlight, is that as we impact our patients' lives and their healing, we impact our caregivers' ability to provide that care. Thank you.
Thank you both for that presentation. We will now move on to the Q&A portion of the webcast. As a reminder, audience members can submit questions using the question tool to the left of the screen. So for the first question, who did all the systems integration work of Epic and the other systems, and what kind of hurdles did you encounter with the different vendors and partners?
Why don't you start that one, Ruchi?
A lot of different teams. It definitely took a village. It wasn't a single person. It wasn't a single team. It was definitely a large-scale effort of working across all the different teams and touch points that there are with Epic and even these other systems, working with these vendors, understanding what the requirements were in order to actually make the product do what we wanted it to do, and then collaborating to make it actually happen. So it wasn't one person. It took a village.
Let me just, thank you, Ruchi. And let me just add that village, for the most part, was our Epic clinical systems teams internal to us, as well as the Oneview partner. And then certainly Ruchi's digital team. It was sort of those three primary teams.
Thank you. What do you consider your greatest successes with this project? What about missed opportunities?
Ruchi, why don't you take the successes?
There's so many. I mean, really, things like the example that Dr. Testa, you mentioned before, where, we had 2 COVID patients. I think it was a husband and wife, right? They were in the same building, and they couldn't really be there for each other in any way. But being able to connect them at this very difficult time in their lives, while still being able to really provide that care for them at the same time, is just one of many examples. But really having that patient impact, but also being able to improve the care team's ability to provide patient care, returning time to them to even be able to spend on patient care, being able to pull in the family to be a support network for the patient while they're in the hospital, once they've left the hospital, making sure the patient knows what they need to know to make sure that once they've left the hospital, they can continue to care for themselves or their family for them, depending on the situation. Just so many successes.
As far as a missed opportunity, I'm going to say it lands squarely in our world, but it was sort of a missed opportunity in partnership with our operation and clinical leads. We had really good uptake with nursing bedside who really have to support in many ways. They're going to get hit with the questions first, and they were very supportive of it. And willing to sort of dig deep and to help patients use it when they first sort of were learning about it themselves. On my wall, I'd say, we still have to catch our breath. And I think there's an opportunity to sort of put in an introduction tool, video connection that explains all the functionality and in offloads from our nurses and our patient experience teams, the ability to explore and fully utilize. I will tell you, I spent just over 12 days in the pavilion as a family member of a patient who had a stroke, and I loved it. My family was living in that room when my dad was recovering, but I found things that really surprised me that I didn't know about that were incredibly helpful. But if I don't know about this functionality, and I have Ruchi's cell phone because I could text her and ask her what this button did, I'm realizing that there's some untapped potential that we still have to do a better job of getting out there.
Yeah, 100% echo that.
Thank you. We are not as large and well-funded as NYU Langone, so tell me what we can do.
I missed the question. I apologize.
Yeah, no problem. We are not as large and well-funded as NYU Langone, so tell me what we can do.
Ruchi, let me jump in first. I'll hand it back. But yep. I will say point blank, the cloud solution that Oneview brought to us in our time of need was an out-of-the-box turnkey, frankly, fairly affordable option that required much. Was sort of that small, medium, and large, that Goldilocks, what we needed at a moment. And I'd say every bit of integration is not necessary. There are things we still need to integrate, and there are ways we're going to push Oneview to catch up to us in some ways. And we will do the same catch up with them in certain functionality. But I think there is a clear advantage to the hosted, to the cloud solution that is really light footprint, and sort of turnkey in that regard, as I had called out earlier.
Thank you. What about integrating your content? Where does the content come from that NYU delivers? Can we use our own homegrown content, or is that provided by other services?
So we have a mix. So we've got content that is homegrown that we've created that's included on the Oneview platform. And then we've also got content that comes from other content provider vendors, both of which can be delivered through the Oneview platform. So either one is possible.
Thank you. How was the adoption process for senior age patients with the whiteboard and tablet technologies you implemented?
I have to say, similar to what we've learned over the last 14 months, once you get an older patient, a more senior patient, engaged and sort of comfortable and up to speed to learn themselves, our experience has been they're actually a much stickier user. And I've seen this with, one of our very first virtual urgent care patients was a 104-year-old gentleman who navigated the system completely on his own and had a very satisfying encounter. I know this both by his his reviews as well as a clinical outcome. So I'd say there needs to be an awareness. We can't simply be ageist and acknowledge that and simply fall back on old people can't use tech. We all know that's not the case. We also all know that it can be more challenging, and the technology is not always optimized for a more nearsighted individual or less dexterous. That said, it seems to be, our lesson learned is a little bit of additional energy, activation energy put in up front goes a long way. And we've seen this from, I would say, almost all of our patient-facing clinical systems, like MyChart. If we can get a little bit of additional energy put into the patients being facile with it, which may mean a little bit more at elbow support in the beginning, it pays dividends beyond what that might happen with a late adolescent to mid 30-year-old patient.
Thank you. For your next question, did Epic have the functionality you needed and you chose to not use them, or was Epic supportive of Oneview?
Ruchi, jump in if I'm wrong, but my feeling is I'd say yes to both of those. So we looked at MyChart Bedside, and it did not have everything that we were looking to do in something as deeply integrated as MyWall is to our new pavilion, or as scalable is as we needed it to be. That said, Epic was incredibly supportive of our work with Oneview as another very strategic partner of ours. And they complement one another. There are some things that either have to come from the EHR and remain a single source of truth, and can be surfaced in different ways. So, for example, Ruchi's one of her early slides showed that the estimated date of discharge we display for patients. So that's something that is very important to us, and it is drilled into our clinical teams that should be put up, that should be documented within the first 12 to 24 hours, and it can change of a patient's stay, and we surface to them almost immediately to manage expectations. I appreciate that some units that's more challenging, and in some units we suppress that. But we can't have two sources of truth. We can't have a mismatch of the estimated date of discharge. So the truth has to stay in the EHR where the clinician and care managers have documented it. We have to have one source of truth because patients can see that also in MyChart Bedside Mobile, which we've also gone live with, which is essentially the BYOD equivalent of MyChart Bedside, where estimated date of discharge is also surfaced to them. So the very last thing we need is a mismatch from what's on the wall versus what's in the app, which is shared with proxies quite extensively outside of the hospital. So it's not an either or for us. It's always been a complement, and we load MyChart on these devices.
Thank you. What were the hospital IT concerns with the solution, and how was the hospital IT concerned with access and security addressed?
So, Ruchi, I'm happy to defer to you on this. I know there was a lot of effort and a lot of solutioning needed in our early days around ADT events and wiping the tablet and keeping that in sync and making sure that if a patient chose to log in with their own Zoom account or their own Netflix account, that those would not carry forward to another patient. But perhaps, Ruchi, you'd want to speak to that.
Yeah, those are kind of the things that were initially coming to mind. But a lot of the integration and making sure that, you know, you don't end up with PHI showing up for the wrong patient, or the Epic information not showing up correctly, or anything a patient logs into, the next patient shouldn't be able to see. Those were kind of some of the security concerns that we initially had. And then other things like accessing parts of the tablet that you wouldn't necessarily want a patient to access, because then it opens up risks for security vulnerabilities. So, for example, we use Android tablets, and being able to access the Android settings, or on a Windows computer, accessing the actual Windows operating system, things like that. So part of that was solved by, a large portion of it really was by the Oneview platform working in a way that limits all of that stuff. So on the tablet, for example, it is in kiosk mode. So a patient can only access the MyWall application and navigate around through that and open whatever other third-party applications that we allow them to. But then with the Oneview kiosk mode and our MDM combined, we essentially lock down the device from being able to do other things that we wouldn't want them to be able to do. Similarly on our Windows platform. And then with all of the information between patients, from one patient to the next, having that device swipe that is initiated by a discharge or a transfer. So when patient movement events occur, the device is completely wiped of any of that content that a patient might have used or logged into using their personal logins, so that the next patient that comes in cannot actually access any of that.
Great, thank you. What kinds of tech support and training services are needed to support patient or provider adoption and the use of the platform itself? Yeah, so we have a few people dedicated to supporting not just this platform, but any number of different clinical systems and other systems within our Kimmel Pavilion building. And it's not like an entire dedicated group of people. This becomes one application among many that they're supporting. So the support really is pretty light from a technical support perspective. We don't have too many issues on a regular basis. The system doesn't really ever go down. The downtimes are pretty limited, except when we're doing intentional maintenance and things like that. Or if, for example, our TV service provider, there's an issue with them, or like a network issue, but those are more wide issues, not targeted towards this platform. So the technical support is actually fairly limited, which is one of the benefits of the system. And on the flip side, for supporting clinicians when we're deploying this product, we do have a number of different groups that really help to train clinicians on how to use the product. So when we're deploying one of the variations that is purely in guest mode, that one is a lot simpler. It's usually just some of the entertainment aspects, as well as some of those connection apps. And the need to understand every single piece of it is somewhat limited. They're all consumer-facing apps that most people know how to use. But when we start moving to the Epic integrated side of things, then there are aspects that a nurse would need to understand from a workflow perspective, what they're doing in Epic and how it'll impact the Oneview platform, and likewise backwards. If a patient does something in the Oneview platform, like reviewing some of their patient education, the fact that that will write back to Epic and provide a trigger within the Epic system that the nurse is looking at,
so that she or he knows that a patient has reviewed the education and then can do the next step of the workflow. So there's a little more involved on that side.
Great, thank you so much. And we have time for one more question. But Brandon Belcher, head of the North American sales, is on the line today too. So we'll make sure that Brandon follows up with any questions that don't get answered today. But for the last question, what are the key areas of innovation for the platform in the future?
Yeah, so we've got tons of different innovations that we're looking at, and some of them are actually really low touch and pretty simplistic. So one of those missed opportunities that Dr. Testa was mentioning earlier is actually one of them. So having some form of disseminating information about all of the great features and functionality that is on the product in a way that is not physically on the MyWall platform is actually one of them, so that patients know what they have access to. Then other things innovation-wise that we're looking at are things like voice control for, and I think someone alluded to this earlier, I don't remember if it was me or Dr. Testa, but patients who have limited ability to actually physically use the product in its current form and the way that you can navigate it, with things like voice control that may open up opportunities for someone that can't physically touch the device. And so they would still be able to make use of all the great features and functionality on the device.
Wonderful. Thank you both so much. That concludes today's patient engagement HIT presentation. Special thanks to our speakers, Paul and Ruchi, our audience, and our sponsor, Oneview. Thank you all and goodbye.